Mary Frances, whenever I speak on PV, I'm always challenged at the end of the discussion by cases that practitioners have where they've done the entire evaluation and cannot find diagnostic criteria for PV or for a secondary cause. And they've looked for sleep apnea and all the things, even congenital causes. Have you seen that kind of patient, and what advice would you give?
Yes, I think there are these patients. Over the years, we've spent a lot of time investigating and finding new congenital mutations, and I'm aware of the fact that many of the patients that I had 20 years ago, we've now found a series of congenital mutations, but you're still left with a group in whom you find nothing. We're getting to the point to say they should have extensive genetic evaluation if they're young, particularly if they have a family history. But there are still occasional patients who you find nothing that look like a PV, and you do not find a mutation. And that leaves you, is there such a thing truly as JAK2 negative erythrocytosis? All the groups give criteria for that, but they're have become over time a vanishingly small number of patients. The other thing that I think is worth looking at is to repeat their JAK2 mutation screen. I've certainly investigated recently a group of these triple negative ETs, and when you go back, sometimes you find low-level JAK mutations, and even we found CALR mutations. And my recommendation at the moment is that these people should have their look for the mutations repeated every few years. And the final point I'd say is some of these patients, when you've followed them up over time, the erythrocytosis seems to have disappeared. You know, is it something that was going on in their life that we don't know about that has gradually disappeared?
I'm sorry to interrupt, but the WHO, I think, recognized this very small group of patients that would have a phenotype of erythrocytosis and yet don't have the JAK2 mutation. And in that sense, at least the recommendation is to obtain, if again they meet the criteria for erythrocytosis, then to obtain a bone marrow, then rely on the one minor criteria, which is a subnormal erythropoietin level. And I think, again, it's probably a very small patient population, but I want to take a moment to say that even though the WHO brought down the level of hemoglobin from 18.5 to 16.5 and from 18 to 16 in men and women respectively, I think there was a sort of an oversight thinking about the iron parameters. And I think that sometimes can complicate the picture if you have a patient that may present with thrombocytosis and may not have hematocrit or hemoglobin that's high enough for a diagnosis of PV, but they happen to have 0 iron stores. Then there's your example of someone who may actually have that type of overlap. So I think, and I agree with your point about doing a bone marrow biopsy, because that will allow you to assess the iron stores in that situation and perhaps put all the clinical data together to arrive at the right diagnosis.
So we have in the BSH just undertaken an extensive exercise reviewing all the literature for the last 15 years and then coming up with criteria for polycythemia vera. And we actually did not think that the WHO hemoglobin levels were justified, and actually stayed with the hematocrit we had before. But very much you have to make the point, beware the iron deficient patient. The other thing on risk stratification, when we looked at the literature, we thought that the high risk should be people over the age of 65 rather than 60. Because you can, when you look at the literature, it actually is the cutoff in all the studies is at 65 rather than 60. So we have said that high risk is over 65, previous thrombotic events, etc., rather than 60. That may reflect somewhat as doctors get older, but it does seem to make sense from the evidence base.
Yeah, I think my takeaway is, many of these are really continuous variables. So I think the, very active, astute clinician trying to weave all of these factors together, I think is really key. Because with any of them, does 16.4, is that any different than 16.6? Well, of course not. We all know one 60-year-old is not the equivalent of another 60-year-old. So good clinical common sense, particularly as it relates to these areas of continuous variables where the cutoffs have been statistical but not scientific in origin.
So I'm going to put myself on the spot here with this panel of experts and say, when I have a patient, I've done the entire evaluation, bone marrow, everything, and I cannot find a cause of a relatively mild erythrocytosis usually, I will recommend a baby aspirin, but I would not phlebotomize, and I definitely wouldn't give cytotoxic therapy. Is that what you do as well?
Yeah. And follow up.
And follow up, yeah, very important. They stay in my clinic, absolutely.
Yeah, I mean, I think, again, good common sense in terms of the clinic. One, I definitely do believe there are individuals that have a mutation negative workup who truly still have PV, you know, and perhaps being at a reference center, I see a higher number of these, even after we've done all of the other testing. But you're right, there still is always a little uncertainty with these. I'd say I particularly try to avoid any sort of cytotoxic therapy in these individuals. I think phlebotomy is maybe a bit more phenotype dependent as being a more benign therapy.
Jamil, why don't you talk about this disease? Does it progress into anything else?
I think because it's a chronic disease and because progression perhaps happens over a long period of time, the patients may not have necessarily a great deal of symptoms to report to their physician. But I think one of the most important features is to monitor the development of anemia. And obviously, most of those patients may end up being on cytoreductive therapy. And the question there is that due to a drug, or is that because of development of myelofibrosis? And so I find over time, you start to reduce the doses of cytoreductive therapy, reducing the doses of hydroxyurea. I think that's a very important, potentially first sign of disease progression. And then the other thing is, obviously, we need to monitor the symptoms, and we have a symptom expert here, Dr. Mesa, as to spleen-related symptoms, constitutional symptoms, and also looking at the percentage of blasts in the peripheral blood. If someone starts to have 2, 3, 4, 5%, obviously that would be something that may be indicative of disease progression. So we need to continue to monitor those patients pretty frequently and capture their symptomatology and signs of splenomegaly.
How common is it for PV to progress into AML?
I think with time, so acute evolution of from PV directly to AML is extremely rare. I think I read something about 4% perhaps. But the more likely scenario is people go to myelofibrosis, and then from myelofibrosis go to acute leukemia, and the rate of myelofibrosis at about 10 years, about 10%.